In diabetic peripheral neuropathic pain, the difficult question is often not whether a drug can help, but what to do when the first drug helps only partially. Many patients start treatment with a first-line medication, feel some improvement, but remain far from comfortable. At that point, clinicians often add a second agent, even though guideline support for combination therapy has historically been limited. The Option DM trial is clinically important because it studied treatment pathways that resemble real practice. Start with one drug, titrate carefully, and add another only when pain relief is still suboptimal. The key message is reassuring but also practical. Amitriptyline, Duloxetine, and Pregabalin-based pathways produce similar pain relief, and combination therapy provided additional benefit for patients who did not respond enough to monotherapy. Hi, I'm Dr. Akihiro Ando from Tokyo, and I specialize in orofacial pain and oral medicine. Today, I will review the Option DM trial published in The Lancet in 2022. This was a multi-center, double-blind, randomized crossover trial comparing 3 treatment pathways for painful diabetic peripheral neuropathy: amitriptyline supplemented with pregabalin, pregabalin supplemented with amitriptyline, and duloxetine supplemented with pregabalin. Although the condition is not an orofacial pain disorder, the clinical logic is very relevant to anyone who treats chronic neuropathic pain. We often face similar problems across pain medicine: incomplete response, dose-limiting adverse effects, and uncertainty about whether to switch medication or combine agents. Diabetic peripheral neuropathic pain is common and can be highly distressing. Patients may describe burning, electric shock-like, lancinating, or deep aching pain, usually in the feet and legs. The impact goes beyond pain intensity. Sleep, mood, mobility, and quality of life can all be affected. Guidelines commonly recommend agents such as amitriptyline, duloxetine, pregabalin, or gabapentin as first-line options. But the practical question remains: which one should we start with, and what should we add when the response is not enough? That is a gap this trial tried to address. The investigators did not simply compare 3 drugs as isolated monotherapies. Instead, they compared 3 clinically realistic pathways. Each pathway lasted 16 weeks. Patients first received monotherapy for 6 weeks. If their pain remained above a predefined level, a second medication was added for the remaining 10 weeks. This is important because it mirrors what many clinicians actually do in practice. We start with one drug, titrate toward a tolerated dose, assess response, and then decide whether to add another medication. The trial enrolled adults with diabetic peripheral neuropathic pain from 13 centers in the UK. Participants had daily neuropathic pain for at least 3 months and a baseline average pain score of at least 4 on a 0 to 10 numerical rating scale. The 3 pathways were amitriptyline followed by pregabalin if needed, pregabalin followed by amitriptyline if needed, and duloxetine followed by pregabalin if needed. The maximum target doses were 75 mg per day for amitriptyline, 120 mg per day for duloxetine, and 600 mg per day for pregabalin, adjusted when renal function required it. A strength of the study is that it was double-blind and crossover in design. Each patient could experience all 3 pathways over the course of the study, which helps reduce between-patient variability. This matters in neuropathic pain because patients differ greatly in their symptoms, comorbidities, tolerability, and expectations. The primary outcome was the average daily pain score during the final week of each 16-week pathway. The main finding was clear. All 3 pathways reduced pain to a similar degree. The average baseline pain score was about 6.6 out of 10. By week 16, the average score was about 3.3 across all 3 pathways. In other words, pain intensity was reduced by roughly half, but no pathway was statistically or clinically superior to the others. The differences between pathways were very small. Duloxetine supplemented with Pregabalin was not meaningfully better than Amitriptyline supplemented with Pregabalin. Pregabalin supplemented with Amitriptyline was also not meaningfully better than either of the other pathways. This is clinically useful. It suggests that the choice among these first-line options can reasonably be individualized. In real practice, we should consider the patient's comorbidities, contraindications, adverse effect profile, prior experience, cost, availability, and preference. For example, amitriptyline may be limited by dry mouth, sedation, orthostatic symptoms, cardiac conduction concerns, or urinary problems in some patients. Duloxetine may be attractive when mood symptoms coexist, but nausea and other tolerability issues may occur. Pregabalin may be useful in some patients, but dizziness, somnolence, edema, and balance problems need attention, especially in older adults or those at risk of falls. The combination therapy result is particularly important. Patients who had insufficient pain relief after 6 weeks with monotherapy and then received an added second drug had a further average pain reduction of about 1 point on the 0 to 10 scale. In contrast, those who remained on monotherapy had only a small further improvement. Combination treatment also helped additional patients reach mild pain or achieve 50% pain relief. This does not mean every patient should receive combination therapy early, but it supports a structured stepwise approach when monotherapy gives partial but inadequate relief. We should be careful in how we interpret this. Option DM was not primarily designed as a simple monotherapy versus combination trial. It compared treatment pathways. Still, the pattern is consistent with a common clinical observation. If a patient has partial response to a tolerated first-line neuropathic pain medication, adding a mechanistically different first-line agent may be more useful than simply accepting inadequate control. The study supports this approach when it is done carefully with dose titration and monitoring. The adverse events were mostly predictable. Dizziness was more common in the Pregabalin than amitriptyline pathway, nausea was more common in the duloxetine than Pregabalin pathway, and dry mouth was more common in the amitriptyline than Pregabalin pathway. Importantly, combination treatment at maximum tolerated doses was generally well tolerated, with relatively few discontinuations due to treatment-emergent adverse events during the combination phase. This is clinically reassuring because one concern about combination therapy is that side effects might accumulate and become unacceptable. However, we should not overstate the findings. The trial had no placebo group. The authors explained that these medications already have established evidence from placebo-controlled trials and are widely used. But without a placebo arm, we cannot separate all medication effects from expectation, regression to the mean, or the natural fluctuation of pain. There was also meaningful attrition. This was a demanding long crossover study lasting about 50 weeks, and not all participants completed all pathways. The authors performed sensitivity analysis suggesting that missing data affected precision more than bias, but attrition remains a limitation. Another caution is that the study population was specific. These were patients with painful diabetic peripheral neuropathy, and the findings should not automatically be generalized to every neuropathic pain condition. That said, the clinical principle is relevant. First-line neuropathic pain medications may have broadly similar average efficacy, and careful combination treatment can be reasonable when monotherapy is insufficient. For daily practice, I think this trial supports 3 practical messages. First, there may not be a single universally best first-line drug for painful diabetic neuropathy. Second, treatment should be individualized and titrated toward the maximum tolerated dose rather than abandoned too early. Third, when a patient has an inadequate but partial response, Adding another first-line medication can be a rational next step, provided adverse effects, comorbidities, renal function, and drug interactions are carefully reviewed. For clinicians who manage chronic neuropathic pain, this is a useful reminder that evidence-based care is not only about choosing a drug, it is about choosing a pathway. We need to reassess pain, sleep, function, mood, and tolerability over time. We need to explain to patients that complete pain elimination is often unrealistic, but meaningful pain reduction and improved daily life are achievable goals. The Option DM trial does not give us a dramatic winner among Amitriptyline, Pregabalin, and Duloxetine. Instead, it gives us something perhaps more useful: confidence that several first-line pathways can work, and that carefully selected combination therapy has a legitimate role when monotherapy is not enough. Thank you for watching.